Hey everyone, and welcome to this explainer. Today, we're going to act as diagnostic detectives to navigate the high yield and honestly kind of tricky traps of calcium homeostasis together. If you've ever felt like endocrine feedback loops and genetic imprinting were designed just to mess with you, well, you're in the perfect place. Today, we're going to break down the exact molecular distinctions that dictate entirely different diagnostic and treatment pathways. Let's get right into it. Real quick, here is our syllabus for today. Number 1, the Calcium Control Center. 2, unpacking hypercalcemia. 3, a primary HPTH deep dive. 4, the hypocalcemia breakdown. And finally, number 5, treating the calcium crisis.
All right, section 1, the Calcium Control Center. We've got to start by establishing the baseline, right? How does our body actually control calcium? Because without this physiological foundation, the pathology just won't make any sense.
Now look at this, because this is truly fascinating. It's the paradoxical effect of PTH on our bones, and it completely depends on how it's delivered. When parathyroid hormone, or PTH, is secreted or given in a pulsatile, intermittent way, it actually leads to net bone formation. It's highly anabolic. And actually, that is the exact basis for using medications like teriparatide to treat osteoporosis. But if that PTH exposure is continuous, like what happens when you have a hyperactive parathyroid gland, it completely shifts gears. Continuous exposure leads to net bone resorption by indirectly driving up osteoclast activity. So it's the exact same hormone, but it yields totally opposite results based purely on the rhythm of its delivery. How crazy is that? Underpinning all of this is the calcium sensing receptor, or CASR, which sits right on the parathyroid cells. Think of it like a strict internal thermostat. When calcium levels get high, this receptor flips on, and that immediately decreases the secretion of PTH. This is your fundamental negative feedback loop, occurring within literally minutes to keep our calcium levels strictly regulated. Keep this precise receptor in the back of your mind, because it's going to be incredibly important for some of the genetic traps we're going to uncover shortly. Moving right along to section 2, unpacking hypercalcemia. Let's see what happens when those calcium levels soar and the normal rules break down. I want you to slow down and pay really close attention here, because this is our very first major exam pearl. When a patient presents with elevated calcium, your absolute first move, look at the PTH level. PTH is the key differentiating test in hypercalcemia. If the PTH is elevated, or honestly, even if it's just inappropriately normal given how high the calcium is, you're heading down the path of primary hyperparathyroidism or maybe a specific genetic condition. But if that PTH is suppressed, you need to pivot immediately. You're now hunting for malignancies, vitamin D toxicity, or granulomatous diseases like sarcoidosis. And this brings us to a classic trap that examiners just love to set up. You have two completely different conditions that look absolutely identical on a basic blood panel: familial hypocalciuric hypercalcemia, or FHH, and primary hyperparathyroidism. Both of them present with elevated serum calcium. Both of them show a normal to high PTH level. So, as diagnostic detectives, how exactly do we tell them apart? Well, it all comes down to this one specific number. A calcium to creatinine clearance ratio of less than 0.01 definitively diagnoses FHH. In stark contrast to that, primary hyperparathyroidism usually features a clearance ratio of greater than 0.02. It's this incredibly subtle numerical difference, but it completely changes your management plan. And here is why that distinction matters so much. You must always exclude FHH before jumping to surgery, because taking out the parathyroid gland will not fix this genetic mutation. FHH is actually caused by a loss of function mutation in that exact calcium sensing receptor we talked about earlier. It's a completely benign, lifelong condition. If you mistake FHH for primary hyperparathyroidism and send that patient to the OR, you are subjecting them to a totally unnecessary surgery that won't even cure their hypercalcemia. Okay, having safely dodged that trap, let's head into section 3, primary HPTH deep dive, and dig into the most tested culprit of calcium overload. Now, while it's true that most patients today are actually asymptomatic and just get discovered by accident on routine blood chemistry panels, you absolutely still have to memorize this classic rhythmic mnemonic. You know the one: bones, stones, groans, and psychic moans. We're talking osteomyelitis fibrosis cystica causing bone pain and brown tumors, calcium oxalate kidney stones, severe abdominal pain from peptic ulcers or pancreatitis, and systemic neurological symptoms that can range from general weakness all the way to severe depression and psychosis.
This brilliantly illustrates the critical distinctions across the multiple endocrine neoplasia, or MEN, syndromes. Notice how M1 and M4 share a very similar clinical profile. They both feature hyperparathyroidism alongside pituitary and pancreatic tumors, even though they stem from completely different genes. Then you have MEN2A, driven by a RET proto-oncogene mutation, which includes hyperparathyroidism in about 20 to 30% of cases. But here is the big twist. MEN2B. It's also a RET mutation, and arguably the most aggressive syndrome of the bunch, featuring medullary thyroid carcinoma and mucosal neuromas. But it brilliantly skips the parathyroid completely. It completely lacks hyperparathyroidism. All right, let's swing to the opposite extreme. Section 4, the hypocalcemia breakdown. We need to examine the complex genetics and the dangerous diagnostic traps of low calcium. By mapping this out, we can make sense of the confusing world of pseudo-hypoparathyroidism, or PHP. Notice how PHP1A presents with low calcium and high PTH, which is due to hormonal resistance. But then, PPHP presents with completely normal calcium and PTH levels. And yet, despite those major biochemical differences, both conditions feature the exact same physical traits. We call these Albright's hereditary osteodystrophy, or AFO features. Think short stature, a round face, and brachydactyly. So why does that happen? This is a massive exam pearl right here. It's the exact same gene defect, but it depends entirely on the parent of origin. A maternal GNAS mutation causes the actual calcium abnormalities of PHP1A, but a paternal mutation in PHPH only causes the physical features. This happens because the specific gene responsible for the parathyroid receptor signaling in the kidneys is maternally imprinted. If mom passes down the mutation, the kidneys lose PTH signaling and you get hypocalcemia and resistance. But if dad passes down that exact same mutation, the kidney function stays perfectly intact, though the patient still inherits the skeletal abnormalities. Now, let's set up another incredibly dangerous diagnostic trap, this time involving the calcium sensing receptor in ADH1, or autosomal dominant hypocalcemia type 1. Earlier, we talked about a loss of function in this receptor causing high calcium. Well, here we have a gain of function mutation. The receptor is constitutively activated. It's essentially jammed in the on position. This falsely tricks the body into thinking calcium levels are dangerously high, which suppresses PTH and causes the kidneys to dump massive amounts of calcium straight into the urine. And here is the trap. The instinctive knee-jerk reaction to low blood calcium is to prescribe calcitriol and oral calcium, right? But if you fall for that trap in ADH1, you are going to cause irreversible renal damage. The kidneys are already hyperexcreting calcium. If you pump more into the system, it's going to precipitate right there in the kidney tubules, massively worsening nephrocalcinosis. The correct move? The elegant, targeted solution is a calcilytic, like Encolet. It effectively dials down the sensitivity of that hyperactive receptor. Finally, let's bring it all together in Section 5, treating the calcium crisis. Let's review the pharmacological toolkit we actually use to fix this. Here is your battle plan. This timeline bridges the immediate therapies that work in just hours to the heavy-hitting medications that take days to kick in. When a patient rolls in crisis, your very first move is aggressive hydration with IV saline, followed by a loop diuretic like furosemide to literally force the calcium out of the kidneys. At the exact same time, you can give calcitonin for a rapid drop in serum calcium. Then, over the next 24 to 48 hours, you initiate bisphosphonates to inhibit bone resorption, and that's what maintains calcium control for weeks. For the really tough refractory cases, you can layer on medications like denosumab or specific agents like glucocorticoids over the subsequent days. But a quick, crucial warning on calcitonin. Never, ever rely on calcitonin as an ongoing treatment. Why? Because of rapid tachyphylaxis. It is strictly a temporary bridge. While it works beautifully in those first few hours by directly inhibiting osteoclasts, the receptors rapidly downregulate. After a maximum of 48 hours, the drug simply stops working. It is a fantastic tool to buy you time while you're waiting for those bisphosphonates to take effect, but it is definitely not a long-term solution. So as we wrap up this explainer, I want to leave you with the thought. Could understanding these subtle genetic differences in calcium receptors be the key to unlocking the future of targeted endocrine therapies? We have seen today how a tiny single genetic imprint can drastically alter a patient's entire biochemical reality, and how targeted drugs like calcilytics are already changing our approach to inherited diseases.
Understanding these pathways doesn't just help you ace exams or avoid diagnostic traps, it gives you a front row seat to the future of pharmacology. I really hope this breakdown brought absolute clarity to calcium homeostasis for you. Keep connecting those clinical dots, and we will see you next time.